I'm ready. Am I green? Is this thing on? Should I tap it? Yeah, exactly. Okay. A couple of topics that I was asked to cover today were there was a big request for chest tubes. Thank you, Zari. And then I figured since I was here, I was going to kind of address a couple of topics that come up at every single nurse education, regardless of floor, of how do you figure out who the hell to page on our team. As you well know, it's not clear, it's not linear thought process. There's full of nuance, all that sort of thing. I'll kind of spend just a couple minutes on explaining why it's so complex. And then, of course, we'll talk about chest tubes, and you can't have a chest tube lecture without any sort of pain control. We're certainly getting into trauma season soon. I would expect a few motorcyclists this weekend, or maybe even today. So we'll see. Welcome to warm weather. So, I need a clicker.
Oh, wait. Maybe you have the clicker. Real clicker.
Could be.
There's a lot of questions. Oh, no. I think early on. Okay, hold on.
I'm holding.
That was the moment I have the clicker.
I didn't realize that this was.
Oh, yeah, it's there.
Oh boy.
How do you set that up? You say.
I have to watch my language a little bit. It is being recorded after all, so regardless of what is transcribed, it's still a permanent digital recording of my behaviors. Are we green now?
Yeah, you're green.
Okay. All right. What's that?
You're green turned to Regina.
Fair enough. All right, so a couple minutes, or like 30 seconds on what is a level 2 trauma center. Basically, this is all of the high level points of what goes into being verified as a level 2 trauma center. The American College of Surgeons re-verifies us every 3 years, of course, minus COVID. But we basically are able to initiate definitive care for any and all trauma patients, whether they're adults or peds. You do not have to be a designated pediatric trauma center in order to take care of pediatric trauma patients. We have 24-hour coverage of general surgeons, i.e. trauma surgeons, as well as coverage by orthopedics, neurosurgery, anesthesiology, emergency medicine, radiology, and critical care. The other listed surgical subspecialties are not necessary to be a level 2 trauma center. But we also have injury prevention programs. We focus on various different age demographics, from teen car control with our peds, teenagers in particular. There's kind of a big gap in that whole adult 20 to about 50-ish years old, because there's so many things that we adults do that end up in injuries, and most of which we don't really have any sort of way of influencing that patient demographic. But then once we get into our elderly population, we know that elderly falls are a big part of our trauma population, and so we have a number of programs for injury prevention in the elderly in particular. We've got 3 activation levels. So when a patient comes into the ER, they either come in as a level red activation, a level yellow, or a trauma consult. The level red is the whole team, including the trauma surgeon, who has to be here within 15 minutes of the patient arrival. Otherwise, either myself or Julie or eventually Amanda or the residents respond to all level red and yellows to within 15 minutes of patient arrival, and then consult we have an hour. Pretty straightforward. This is who we are, current state. I did include Dr. Fairfax and Dr. Carter. Their plan, as far as I know, they will be with us at least through the summer and partway into the fall. We have Dr. Nolan Rudder coming back to us. If you all remember him, He was a surgery resident. He's in Milwaukee at MCW right now doing a trauma critical care fellowship, 1-year fellowship, and then he comes back to us. So it was a huge, huge win for us. And then we also have, I can't remember the other surgeon's name that we hired, but she's coming to us from Pennsylvania, I think. Someplace out east is where she's training currently. And then there's me and Julie, and I forgot to put Amanda's picture on. Amanda Middendorf is Julie, my partner in crime. She's out on maternity leave right now, and so she'll be back with us in July. We do have a new trauma locum scheduled for sometime in June. I don't remember what her name is or any of her bio. It happened to come across an email. I was like, okay, join the club, add it to the list. It's fine, totally fine. Okay, who to page. So the quickest, dirtiest way is during the day, who wrote the note, page them. I will tell you that the caveat is on Wednesdays. So when I'm on call on Wednesday or on Tuesday night, like I was this Tuesday, then I am gone. I'm done for the day somewhere between 9 and 10 o'clock in the morning, and then I turn my pager red. From there, from there you page Julie or eventually Amanda. Your other backup actually is doing a search to figure out which resident is on call. You can always page them as well. So there's basically 3 options, eventually 4 options, including Amanda, of who to page, residents or one of the APCs. If you can't figure out or can't get a hold of us, then you certainly can page the listed attending on call directly, but please try to exhaust us first. To do a search, I guess, are you all familiar with how to do a search on how to figure out which team? Trauma surgery is general surgery team C. It's something that you're just going to have to remember when you look at, when you pull up the team list for the particular patients. All of our trauma patients are going to be on surgery team C as well. So if you see that, then that's who you can search to page. I have a couple of ideas that I'm floating right now as to see if we can smooth that out. Hopefully we'll be able to have you search by trauma, and then you'll be able to figure it out that way, but I can't guarantee that that's going to happen. The background is we have 6 general surgery teams, and so on surgical digestive, all 6 of those teams have patients on that floor, and so trying to figure out who is appropriate for a general surgery patient on 6th floor is incredibly complex. And so there was a whole lot of misguided pages, especially in the middle of the night, which is really frustrating. As far as paging at night, please keep in mind that residents take call from home. They're not in-house, they're not awake the whole night. So if they get owly with you on the other end, just please keep in mind that they may be getting paged every 15 to 20 minutes by an ICU patient or nurses from all over the place. And so just having that continuous 20 to 35 minute pages breeds an awful lot of bitterness and very, very little tolerance for things. So please give us all a little bit of grace. That being said, it is not excusable or acceptable to be chewed out. And certainly if that happens, bring that forward. You can always page the attending. But if you page the attending in the middle of the night, please be very succinct and just be ready with, here's the issue, here's the question that I have, and here's potential solutions that I can think of. Do you agree? Do you not agree? Does that make sense? Okay.
Shannon, will you touch base on weekend call? Because isn't there like a trauma overnight and then there's trauma day team?
Thank you for reminding me. Yes. So on Friday nights, there is a cross-cover person for our trauma patients. It's listed in. Yes, it's going to be listed as the person listed on General Surgery Team C. They leave, or they're off their shift at about 7 o'clock in the morning. The reason is they cover trauma, ICU, and acute care surgery. So they may be operating all night, certainly in the summertime, taking new traumas. It doesn't, all it takes is 1 or 2 traumas, and it completely monopolizes the whole evening. And then if they've got 3 or 4 general surgery cases stacked up as well, it's just Friday nights are incredibly busy. And previously, when they were on call, on floor call for Friday, and then rounding all weekend, they weren't getting any sort of sleep. So that's for duty hour protection. It's for everybody's own mental health and trying to reduce bitterness and just frustration overall. Thank you for reminding me of that. Okay. I'm way far behind. So I threw this in. Basically, we're going to talk chest tubes now. And so I threw this little clinical vignette in, basically 78 years old, found down. Shortness of breath, complaining of chest pain, O2 sats were 91% on a non-rebreather with respiratory rate of 24. Okay. Adequate breathing or not? No. Okay. So on a non-rebreather, how high is the oxygen turned up on the wall? I heard something. 10? 10 or more, 15 actually. It actually needs to be on 12 or higher. Okay? So they're setting only 91% on 15 liters per minute. Okay? Additionally, respiratory rate, so anything less than a 6-pack, greater than a case, is inadequate breathing. Right? We can all remember that. Memory by association. Right? We live in Wisconsin. Beer trumps pretty much everything, right? So, ineffective breathing. Okay, so what do you think is going on with the patient? Found down, right? We're presuming, look, elderly fall. Should have done some fall prevention. Oh, you didn't know this was active participation? Oh, okay. What's broken? What's not working? All right, rib fractures, pneumothorax. What else? Possibly, yep. What else chest-wise? So you can have air and hemothorax. Great. That's chest x-ray. It's not actually, but I love Radiopedia. There's lots of fun pictures for presentations on it. Normal or not normal? Yeah, exactly. Yeah, you're going, ugh.
I don't even know how to read x-rays.
Okay, so what are you seeing?
A lot of white space.
Okay, over on the left. What are you seeing on the right? Yeah. What is that called when you have a lung that's collapsed and it's pushing on a whole bunch of stuff? Pneumothorax, but what kind of pneumothorax? Tension pneumothorax. Okay, life-threatening or not? Yes. Yes, that is a breathing emergency, absolutely. So what ends up happening is, and this is technically a mild tension, but basically when you have so much blood or air on one side of the chest that is collapsing the lung and it's pushing that lung and the mediastinal anatomy off to the side, what is the big giant blood vessel that runs in the right side of the chest in the mediastinum? Inferior what? Inferior vena cava, correct. What does it do? Takes blood back to the heart. If you have pressure on that and it is collapsing that off, what happens? we don't get blood to the heart. If you don't have blood coming into the heart, you can't have blood coming out of the heart. So this becomes now a cardiac or a circulation problem as well. That's why this is acutely life-threatening. These people will die on you in the next 5 minutes if you don't do something to relieve that. So in the ER, one of the techniques that we do is we take a big giant needle and we stick it in second intercostal space in the middle of the mid-clavicular line, and you hopefully will at least temporarily decompress that until, and basically it buys us time to get a chest tube in. So, whoop. All right, we have 2 chest tubes that we can put in. Do you know what they're called? Pigtail and big, yeah. We can go big or small, right? Yeah. So the big chest tubes are the Argyle chest tubes, right? Those are the ones about the size of your thumb or index finger. In general, we're moving further away from these tubes and more towards the pigtail chest tubes. You guys remember Dr. Clovatanu and all? He was trauma locum, came from Arizona, was practicing at Tucson, Arizona. But for the last 15 years, he's actually been doing a ton of research in Arizona on the effectiveness of pigtails compared to the big chest tubes. Because one of the dogmas in trauma is go big or don't bother at all, right? Dr. Tom Cogbill, previous trauma medical director, said nobody ever died of a bigger incision. That was the mentality of trauma surgeons, right? Put a 36-French chest tube in if you need to evacuate anything out of the chest. But we've shown that that's not necessarily not necessary all the time. Big chest tubes, they bang on the nerves in between the ribs. They may even start to spread the ribs just a little bit if they're too big compared to the intercostal space. They just hurt an awful lot. So then we have pigtails, right? I figured I'd show you what the kit looks like because it is extremely rare that we get to put a chest tube in your patients on the neuro floor. I've done it before, but it's been a really long time, and it was with Dr. Marcos. So it's been quite a while. But basically, we clean the skin, we numb up the skin, we put a needle in, draw back, make sure that we're in the intrapleural space, or excuse me, the pleural space, and then take the syringe off, put a wire in that guides us. We make a bigger hole by dilating it, and then we feed the tube in, and with some particular techniques, we try to make sure that we get the tube up to the top or near the apex of the lung. If we need it specifically guided to the base of the lung because there's a retained hemothorax or a pleural effusion, we usually have interventional radiology help us out with that to guide very specifically. But that's basically what it looks like. When we're done, we pull the stylet out the middle. We pull on a little string that makes the tip curl into a little pigtail, hence its name. We hook it up to suction and treat it just like a big chest tube from there. Ooh. Close. Okay. Troubleshooting. What do we do if the chest tube falls out, gets pulled out? You guys are on neuro, right? You have owly patients all the time. It's part of our patient population, and so occasionally they will fall out. That means if they just fall out with very minimal force, that means that we did a crappy job of securing it, right? We'll certainly take that. That being said, first thing that you do, you take your hand and you stick it right over the top of the hole, okay? That gives you a little bit of time to figure out, first of all, take a breath, take your own pulse. As long as your hand is over the hole and the patient's not actively sucking a whole bunch of air in, they're not going to die, right? If you don't plug that, then they may end up developing a tension pneumothorax, in which case then they might die. But it's going to take a couple of minutes before that happens, so it's okay. Grab a dressing. There should be, with every chest tube, there should be 2 occlusive dressings on the blue towel clips hanging on the pole or somewhere near the atrium or the little tiny box down at the bottom. That's why those are there, and that's why those have to be in close proximity. Take one of those out or take both of them out. Kind of smush the Vaseline around on it, stick that down, and ABD over the top and tape it down really well. Okay? And then certainly page us. First of all, stop the hole, or stop the air coming in and out of the hole. That's kind of the biggest move. Once you do that, you've got time. You can page us. You can do whatever else. But that patient immediately turns into an IMC patient, right? Until we get our chest X-ray and figure out, okay, is this patient going to need another chest tube, or did they just happen to pull it out earlier when we were going to pull it out the following morning anyways? Okay, that buys you some time. When you don't have any drainage in your atrium, I'll back up just a quick bit. You guys have to check I's and O's on patients all the time at various different times depending on how we have things ordered. Please trust that there is a method to our madness when we order Q2 hours, Q4 hour I's and O's. We're watching for something in particular. But when you do mark that on the atrium, please put a date and a time so that we can, when we round, we know exactly, all right, at this time is where this level was. And this is something that on all floors, there's oftentimes a little bit of variation, and I will tell you it's incredibly frustrating if all we see is a line. Because that means that whoever made that line is the only person that actually knows what time that was recorded. In your flow sheets, when you put that in, then like you can kind of deduce that, okay, at this time, and I recorded the output in flow sheets at this time, okay, that makes sense for you. From an information or data collection part, I stay out of flow sheets as much as possible because it's great for putting data in. It's miserable for pulling data out because you have to search through like every 5 minutes, 4 minutes, 10 minutes, and it might be 24 hours prior that what I'm looking for. So all what you put into that input comes over to a report, an accordion report for us, and that's how we look for our morning information of ins and outs and that sort of stuff. So please, time and date stamp on the line. So the big tubes for a pneumothorax, we like to see those titling. Who can explain to me what titling is?
Breath, the pressure changes.
Say that again?
With the breath, the pressure changes.
Yeah. And how do you see that?
The white ball.
Yeah.
Or, yeah, the ball.
Yep, the white ball in the blue water. Right. So when we all take a breath in, our ribs rotate up and out of the way, our diaphragm contracts and drops down, basically creates a vacuum inside of our chest. And so under normal conditions, we decrease pressure in comparison to the outside atmospheric pressure, therefore we're able to pull air into our lungs. If we have a hole through the side of our chest, whether it's being held open by a chest tube or the chest tube fell out and you don't have your gloved hand on, when diaphragm and ribs do their thing, that suction still occurs and air is going to follow the path of least resistance. And so in our chest tubes, we've got that hooked up to water, and that water column prevents any sort of air from the outside being sucked in. But what we really like to see is that column coming up and down with every single breath. That tells us that our tube is patent, that everything is working fantastically well. That's ideally what we like to see. Big chest tubes are supposed to tidle. They tidle much, much easier. The pigtails don't always tidle. For various reasons, they can have too big of a column of fluid and blood in the tube. They may be kinked. all of the holes in it might be stuck in the fissure of the lung or in between upper and lower lobes, and therefore it's not going to be working hardly at all because those holes are basically just plugged. So there's a lot of different reasons that can occur. So if a pigtail is not titling, it's okay. If a big chest tube is not titling, that's also okay, as long as you rule out that there aren't any kinks in the system, there's no clots anywhere, and clots are notorious for getting stuck at that connection point between the chest tube and the connector to the atrium itself. Another cool way to see if they're titling is if there's a little bit of fluid in the tube itself. You can use the bigger tubing coming from the atrium. You kind of hold that up and have them cough or have them Valsalva, deep breathe, whatever. If you can see any sort of movement in there, okay, our system is good. Air leaks. Who can tell me about an air leak? Or if you've got a whole bunch of air bubbles coming through the blue water. Maybe. Okay. Yes. So in our systems, that water does not automatically have air bubbles coming through it. There are other systems out there where you actually want that air bubbling through. If we see one of those systems transfer in with one of our patients, we change those out right away. So bubbles going through the blue water can be appropriate if we have just freshly put the chest tube in and we're still trying to evacuate, go back to what that x-ray looked like, where the right lung was 50 to 70% collapsed down. Early on, we want that air to come out, and so we're going to see that come up through the tube. It'll come and bubble through. If once that has stopped and then now we have more air bubbles, we have to think, okay, there's a couple of things that could be going on. We may have developed another pneumothorax, or the tube has migrated. It's somehow another remaining pocket of air that was previously undrained. That might be being drained. If it's not due to air in the chest, what else might be going on? What's that? Correct. There might be a hole in the system somewhere where that air is coming in. So that can be anywhere from air seeping around where the chest tube hole itself, or the hole where the tube goes through the skin. That could be a hole in the tubing somewhere. Most commonly, it's a connection problem. So where the chest tube hooks up to the double-ended Christmas tree on the atrium tubing. That commonly is an area where we get a leak. One time I have had a leak in the system itself. One time in 12 and a half years is not too bad considering how many chest tubes we put in. So there is Nursing 4015 is a policy on chest tubes that has been revised in the last couple of years that really can kind of help walk you through how to troubleshoot that. Okay, if you have an air leak and it's not a fresh chest tube, then go back to that policy and kind of just read through and, okay, how do we make sure that there is not an air leak anywhere in the system? Trying to remember my next slide. Okay, questions about chest tubes at all?
What's the best dressing over a chest tube?
The honest answer is it depends on the surgeon. Oh, sure. What is the best dressing for a chest tube? The honest answer is it depends on the surgeon, which means that there isn't a best one. There's just 10 different ways that we can do it, and depending on tiny nuanced details is going to, yeah. So that's the full disclosure true answer.
So you just copy what was done after surgery?
Pretty much, yeah. Yes. that policy does have some of that. So I have one surgeon in particular who does not like Vaseline gauze around chest tube sites. Okay, and the thinking is it's kind of like a Band-Aid. You stick a Band-Aid on your finger, you take it off in 4 days, what happens? Your skin's all macerated underneath of it, right? An occlusive dressing will keep that wound really wet and oozy, and certainly if we don't change it, there's blood products that are there, skin irritation. It's warm, it's moist, there's bacteria there. It's a great breeding ground for bacteria, whether they cause an infection or just bacterial overgrowth. It's a great environment for that. That being said, if there is any sort of an air leak or there's leaking around that, okay, now we need an occlusive dressing. With the pigtails, we do not need to put Vaseline gauze around the chest tube site itself. That is always a dry gauze. In the first 24 hours after a chest tube has been put in, leave the dressing alone. If it's saturated, reinforce it. After 24 hours, take it down and change it. And those dressings, just like any other dressings, those dressings need to be changed once a day. Clean it as best as you can. Saline wipes work pretty well to kind of help break things down, but basically take care of it just like you would a regular cut. Wash it every day, keep it clean, keep it dry. And fortunately, those heal really, really well. We do not use antibiotics routinely for any chest tube that we put in, and the data says that chest tubes get infected less than 5% of the time, in spite of the fact that it's a really dirty procedure. Because especially from our trauma patients standpoint, they're in the ER. If they're crumping and they have a chest X-ray, like what I showed before, we're going to be putting that tube in quickly, and we'll deal with potential infection risk later on.
What's the rationale behind the occlusive dressing, just to keep it moist?
No, the rationale is so that you reduce the risk of air seeping in around the chest tube, and that's primarily on the bigger chest tubes or the Argyle chest tubes. In order to put those in, I have to make an incision as big as the chest tube will fit, plus my finger and a little bit of wiggle room, because when we put those in, it is cut through the skin, big clamps to spread the soft tissue and spread the muscles in between, and then with a sharp clamp, we poke in through the pleura that lines the inside of the ribs, and then we spread. And so I have to stick my finger in to make sure that my lung is swept out of the way and that I'm not in the liver and too low. And then I have to guide that tube in, and the only way I can do that is with my finger. So therefore, the big chest tubes really usually are an incision about 3 times the length, or 3 times the diameter of the chest tube. The larger the BMI, the bigger that incision is going to be, because you have more depth, and you can't really work that deep into a hole without making that a little bit bigger. All right, pain management. Yikes, I am way over in time. I'm going to skip this slide. Okay, if you remember nothing else from anything that I have ranted on for the last 40 minutes, it's this slide. Every single one of our trauma patients has pain, right? It's really important for us to make sure that we take care of their pain, especially early on. It's pretty clear in the research that in the short term, the sooner we can get on top of somebody's pain or make their pain tolerable, the overall less pain medicine that they will end up needing. And there's also correlation with shorter duration of needing pain medications, even in the outpatient setting. And so we've all taken care of patients where we've just struggled with their pain control for the first 24 to 36 hours, and we all, we can think back and go, wow, we really, really needed to use much higher pain medicines for much longer, because what ends up happening is that kind of primes their brain to, I'm having pain and I'm really afraid that this is going to hurt like hell and that we're not going to have our pain under control. These are the opioids that we typically use here. There's some other variations as well, but we use a lot of fentanyl. We use a lot of Dilaudid. On the trauma team, we don't use morphine ever. It's kind of a dirty drug in a way, in that it has there's a big histamine release. It impacts dopamine. It's not just mu receptors. Its metabolism is and oxycodone. I put OxyContin on and PO Dilaudid on too. That we don't. I can't remember the last time we used OxyContin or MS Contin, unless somebody has come in on that chronically. We don't use it. Not for the acute hospital setting. Fentanyl kicks in 2 to 3 minutes, but it wears off in 15 minutes. When you see fentanyl, 25 mics, Q1 hour, we are going to push our patients into, if we're having to use that frequently, they're going to be riding this fentanyl pain roller coaster, right? You take the edge off of their pain, 15 minutes later, their pain comes back, and then they sit for 45 minutes, right? That works great for those times when we're doing something to them, whether it's moving them to the chair or whatever, where they have this big spike in pain, but we don't expect that spike to last for a while. Just kind of a quick take the edge off of that pain and then settle them back in. Dilaudid takes 5 to 8 minutes to start to work, but it doesn't reach peak effect for 15 to 20 minutes. But the good part is that ends up lasting for about 45 to 50 minutes. So oftentimes you'll see, certainly in my patients and Julie's patients, we tend to use IV Dilaudid rather than IV fentanyl. The residents are kind of all over the place. Oftentimes it also depends on what's going on, what the patient was doing in the ER as well. Bottom line is, we are neither going to create nor are we going to treat any sort of opioid addiction in the first 24 to 48 hours of taking care of our patients. If we undertreat their pain, we have a higher correlation with long-term opioid dependence and misuse. So we need to be pretty aggressive right away, but understand that this is in the context of acute pain. Worse in the first 2 to 3 days. Once we get on top of it, then everything starts to settle down just a little bit. PO Dilaudid is kind of miserable dosing. It says that it lasts for 4 hours. Every single one of my patients says that's garbage. It's 2.5 hours, and by 3 hours they're ready for another round. So, and I think here in the hospital I think Epic is every 3 hours. So if you would like me to do any sort of complex dosing for you where you're continuously giving something every hour to hour and a half, I can use PO Dilaudid, but for that reason I try to stay away from it because it's just a pain. Other drugs or other ways that we can take care of pain, we use a lot of Robaxin. Occasionally Flexeril. Neurosurgery historically had used Scalaxin for some of their acute back pain stuff. Xanaflex is another one that, as an outpatient, depending on insurance formulary, we have to use that. Soma is something that this is not working. Okay. I put that up just for completion. Occasionally you'll see that that somebody is taking that as an outpatient, but that one actually has an incredibly addictive capacity, and you have to have special pain medicine clearance in order to initiate that. NSAIDs, Toradol, ibuprofen, Celebrex, aspirin. Occasionally we use epidurals, but it's not very often, certainly more often in the summertime when we've got more complex patients, and then sometimes we'll do rib blocks as well. The downside to those is we only get about 8 to 9 hours out of that. But we can, oftentimes we'll use that on our elderly patients where they're cheap dates. You give them 2.5 of oxycodone and they're snowed, right? We just have to be careful with that. So regional blocks are nice. It's truly a short-term benefit. I think I talked about pretty much all of these already.
Shannon, I've noticed in years past, trauma uses ketamine a lot. Are we still doing that? Are we getting away from that?
We're not getting away from it actively. We just haven't had patients that, I actually need to update that slide. Thanks. It's a ketamine drip on the floor is certainly a possibility. It really ends up being ketamine drip versus an epidural. And it's way easier to get a ketamine drip than it is to have an anesthesiologist put an epidural in. Plus, it's much lower risk as well. Sticking needles in spines, infection risk. So you guys have taken care of people with epidural abscesses, spine abscesses. It's bad news. But yes, we will use those. I'm over my time. That's all that I have. Questions for me at all? What have I confused you on?
Well, thank you.
Thanks.
Thank you.
We can always reach out to trauma and Shannon specifically if there's questions.
Yep. Julie too.